Now, according to, I guess, the statistics that were in the reference that I was looking at, there are 4 transfusion reactions per million transfusions. That doesn't seem hardly possible, does it? Seems like that's very, very low. And in fact, it probably is. Transfusion reactions are very underreported. A lot of times you won't know that a transfusion reaction has actually occurred. The patient is already running a fever because they have some sort of an infection, and you give them a unit of blood and they continue to run fever. It's hard to know whether or not their temperature elevation is due to their clinical condition or their unit of blood. So in that case, it's really up to the clinician to decide whether or not to call a transfusion reaction. They're supposed to pre-medicate in situations like that, but sometimes they don't pre-medicate, or they pre-medicate too early, so that by the time the transfusion is, halfway finished, the medication wears off, acetaminophen or whatever they've given them has worn off, and all of a sudden their temperature rises. Okay, so is that temperature due to their condition, or is it due to the transfusion? We can't do anything unless the clinician calls the transfusion reaction, and that would be physician primarily. The nurses are instructed to take pre-transfusion vitals, and that will include blood pressure, temperature, respiratory rate, and pulse. And they record it, and then they start their transfusion, and after 15 minutes, they're supposed to take it again. And they ask the patient, how do you feel? Do you feel okay? Patient can't talk, can't tell them. It doesn't go right. So transfusion reactions in surgery are the scariest transfusion reactions of all, because the patients are anesthetized and they can't tell you that something's not right because they're just getting that transfusion. So you have a patient that is getting their transfusion. Do you feel okay? Are you cold? Do you feel like, there's pain anywhere? You get people who call pain and everything. They're itchy. Anything hurts, whatever. You have to be able to weigh one against the other to know what is due to the transfusion and what is due to just their clinical condition. Okay. Let me go the right direction these days. Where'd you go? Why is that coming up? That was my first script. Okay. So transfusion reactions can be divided into different categories. They can be divided into acute and delayed, hemolytic and non-hemolytic. So think of playing Foursquare. My kids always make it something that we play with my kids. Play Foursquare, so you have your Foursquare. So you have acute hemolytic, acute non-hemolytic, delayed hemolytic, delayed non-hemolytic. The blood supply, as it stands right now, is probably the safest it's ever been, because we continually add more tests onto the donor units that we call standard testing. We have a questionnaire that's supposed to encompass anything that would reflect high-risk activity that might relay something that would cause the blood to be tainted in some regard. There's a little sticky thing that they started because there's a situation where people would be basically pressured into donating. Greek Week is big at the hospitals because, I think we talked about this last week, Greek Week used to be a big thing because they'd make all the pledges go and donate blood. And they'd make them donate numerous times under numerous different names. Well, if you are an IV drug user and nobody in your frat knows that you're an IV drug user and you shouldn't be donating blood, you don't want want to tell them that and then not get all the points or whatever you get for a fraternity for donating your units of blood. So now they have a little sticker that nobody can see, and it says use or don't use. So if you're with somebody who's telling you, oh, we need to go donate blood, but you know that that unit of blood should not be given to anybody, you can donate blood, pull that sticker off and its barcode. Nobody can know whether it's use or don't use. And when it goes through the processing, they'll scan it. And when it says don't use, it just gets sequestered out of the donor pool. So that was really a good way to be able to eliminate portions of the population that might otherwise donate, knowing that they really shouldn't donate. Standard transfusion, or standard testing for donor units is going to be an ABO/RH. That's going to be one of the cases where you're going to want to do a weak D if your D is negative. You're going to do an antibody screen. If your antibody screen is positive, it doesn't mean you can't use the cells. It just means you can't use the plasma. And if you do use the cells, you'll probably have to wash the red cells in order to be used. But you're going to do an antibody screen. They test for hepatitis B surface antigen, hepatitis core antibody. They should do an RPR, which is, has been under controversy last few years, or probably longer than that, because syphilis doesn't survive in the refrigeration. And so therefore, it doesn't really matter whether you do an RPR or not. FDA wants it, AABB doesn't. So FDA usually wins in these cases, so we're still doing RPRs as of last month. We're still doing it. They do West Nile viruses, Chagas disease. I mean, they just add more and more testing on. They do NAT testing for HIV 1 and 2, HTLV 1 and 2. Of course, if anything's positive, they have to do the confirmatory test because those are all screening tests. You can test for CMV, but it's not done on every unit of blood. But you can test for the CMV. You can test for hemoglobin S. So the testing that's optional, that's not on every donor. Okay, so let's talk about acute and delayed hemolytic first. Okay. Acute hemolytic is the one that is most deadly. That's the one that we want to prevent. That's the one where you cross-match the blood and the blood is perfectly cross-matched and perfectly compatible and you've done everything right and you send it up and the nurse walks into the room and the blood is intended for bed A and she promptly goes, hangs it on bed B. And bed B is in the same blood type. The ABO antibodies are high titer. They're an IgM antibody for the most part. They're going to bind complement. It's going to set your entire complement cascade in works. Lysing, a lot of hemolysis. You can go into renal shutdown. You can go into shock. You can die. Doesn't mean you have to. If the nurse is paying attention, that wouldn't happen to begin with. But if they go in and identify the patient at bedside before they start the transfusion, that wouldn't happen either. If she's taking her pre-transfusion vital signs and takes her 15-minute post-transfusion vital signs, she'll notice that there's something wrong. If she's asking her patient, do you feel okay? He probably does. He doesn't feel so good. So it doesn't need a death sentence in every situation. I've seen O people who've gotten B blood and lived to tell about it. I've seen O people who've gotten B blood and only gotten a small volume and died. So it depends upon the individual, depends upon their circumstances, but we want to prevent it. It's the most preventable transfusion reaction that we have, and it's the most severe transfusion reaction that we have. So let's prevent it so we don't have those severe transfusion reactions. Now, most of the time it's an antibody that's in the patient's blood, so anti-A or anti-B or anti-A, B, that reacts against the donor cells. But there are certain circumstances where you may actually have an antibody that's in the donor's plasma that reacts against the patient. Now that's usually not quite so severe because there's a finite amount of antibody in that donor. So once it's used up, then there's not going to be no more produced, and that's going to be the end of the transfusion reaction. But it can happen. We had one not too long ago that they called us from my staff, and there was a donor who had an antibody, and the donor unit had come over to us. And so then we had to go back and do one of our look backs to see who got the unit of blood, and then we had them draw a screen. They sent us the screen, and sure enough, the patient had a passive anti-cal that they had acquired from the donor unit that had somehow or other slipped past all of the checks and balances. So it can come from different areas. Delayed hemolytic can be primary. So you can have negative screen, and I can give you a unit of blood. And with all those countless antigens that are on that donor unit, you notice that there are a few of them that aren't self, and you start forming antibodies against those antigens. So eventually the titer is going to rise high enough. It's going to start attaching to those donor cells and taking them out of circulation. You have a positive direct Coombs, your hematocrit will go down somewhat, although hopefully your bone marrow is able to compensate. Your bilirubin is probably a little bit higher. Your haptoglobin could be a little bit higher. But it's a risk of a transfusion. We've done all the testing, we've given you the blood. Your physician says you need this blood. Risk of a transfusion, you will be sensitized against some of the antigens on the red blood cells. Most of the time, that doesn't happen. Most of the transfusions on those 72,000 units of blood that we give every year, the patients don't require antibodies. But because they do, that's why we have to opt. You can also have anamnestics. So you went to Sacramento and you had a transfusion and you developed anti-JKB, and that was in 1989. Then you hopped around the country and you ended up in Gainesville, Florida. Well, you're in a motor vehicle accident on I-75. You come into Shands Hospital. We do a type and screen on you. You have a negative screen. We don't know what happened in Sacramento, California in 1989. Screen is negative. We give you some blood. Chances are real good. There's some JKB on that blood. All of a sudden, your immune system says, "Whoa, wait a minute. I have an antibody around here somewhere. Let me see if I can find it. Oh yeah, here it is." It starts producing the anti-JKB. So you have an anamnestic response, which shoots up higher and faster than the primary response. Now, did we do anything wrong? No, we didn't. Because oftentimes, there's an antibody that will drop down in titer if it's not being constantly stimulated for production. Now, the ones that are notoriously known for that are the JKA and JKB. They will drop down in titer. They're below detectable limits. But the antibody, the memory cells are there, and you can get the anamnestic response based on the introduction of that antigen again. Okay. Most of the time, the patient will have hematocrit, we'll give them blood, their hematocrit will go up, and then after a couple days, all of a sudden, it will go down again. LDH might be elevated, bilirubin will be elevated, haptoglobin may be elevated, and they send it back to the blood bank because they want some more blood. And lo and behold, we have positive direct Coombs, and maybe we have an antibody in the plasma. And sometimes we don't, because sometimes as the antibody is being produced, it's all getting sucked onto those donor cells, and there's nothing free in the plasma, which is why we have to elute off the antibody from those donor cells so we can determine what it is that's coating the cells. Is it a drug-induced, or is it really a transfusion reaction that we were unaware of prior to this happening? Everybody good with that so far? So far, so good. Now, there is such a thing. We did notice over the years when you're dealing with sickle cell patients and thalassemia patients that a lot of times they will show the signs and symptoms of a transfusion reaction, but when you do the direct Coombs is negative. And so we're always kind of like scratching our head thinking, okay, there's got to be some mechanism here causing that to happen. And they have determined that in some cases, and it's usually the patients who are chronically transfused, the sickle cell patients and the thalassemias primarily, that they have hyperhemolysis. So what happens is you transfuse them so much that they start making almost an autoantibody that reacts with their own cells and the donor cells, and they start hemolyzing everything. And so you run up against that. They categorize that under delayed hemolytic reaction, although I'm not sure that I quite believe that it's there, and the jury's still out as to what the mechanism is that causes it, except for the fact that they're chronically transfused. Anything else I want to tell you about this? Okay, so acute non-hemolytic. Acute non-hemolytic is circulatory overload, also known as TACO. Transfusion-related acute lung injury, which is TRALI, sepsis, which is TAS, allergic. You can have air embolisms. You can have mechanical, I guess that would be under acute. You can have, what kind of things we have? Febrile. You can have, and you can have anaphylaxis, which would be like a severe allergic. You can go into hyperkalemia. You can go into hypothermic. You can citrate toxicity. There's lots of things that are non-hemolytic that can be acute. Okay, so the most common one is febrile. Febrile is patient gets transfusion and spikes temperature. Most of the time, temperature is because of the white cells or the cytokines that the white cells produce. You can leukoreduce your blood cells and reduce the number of febrile transfusion reactions. We went universally leukoreduced a little over 2 years ago, which means that every blood product that we have that comes into our building has been pre-filtered. So the number of transfusion reactions that were due to febriles has gone dramatically down. Now you can filter blood at 3 different stages. You can filter the blood at collection. You can filter the blood somewhere between collection and transfusion, and you can filter the blood at bedside. So they put an extra filter when they're transfusing it, and it'll all take the white cells out. If you filter it at collection, you'll eliminate most of the cytokines because the white cells haven't been in the unit of blood long enough to really, produce too many cytokines. If you do it somewhere in the middle, you get some cytokines, and if you do it at bedside, you get rid of the white cells, but you don't get rid of the cytokines. There's pros and cons to each of them, as there is to just about everything. But if you want to reduce your febrile transfusion reactions, most of the time, leukoreduction is the way to go. Not every place is going to do that because, of course, that's going to be additional cost. So that's going to be facility driven. The temperature elevation for febrile is usually 1 degree or at more. There's really no evidence when you do your testing. You can find nothing amiss. Everything was done. Everything is cross-match compatible. Everything's good. But you still have this temperature. If you have a temperature, obviously you have to rule out, is it due to your condition? Is it due to TRALI? So TRALI is one of those other options over there. And TRALI is a phenomena that was found primarily with plasma products that were drawn from multiparous women. And basically, it's a lymphocyte antibody, and the aggregates get caught up in the lungs, and they have, you have to have chest x-rays, but it looks like, for all practical purposes, it looks almost like an acute hemolytic transfusion reaction, but there isn't one, and it's due to the plasma. So with circulatory overload, you take a skinny old person or a little kid and you try to give them too much blood too fast. So you send them into circulatory overload. Sepsis, obviously there's bacteria that's growing in the, because that would be bacteria contamination when the sepsis level of patients be septic too. But you have bacteria growing in your units, primarily with bacterial contamination. You're looking at platelets because they're stored at room temperature. Things that go on the refrigerator, you don't see bacterial contamination quite as frequently, and things that are in the freezer, you hardly ever see it. Allergic reaction. People have allergies to the anticoagulant. They have allergies to some of the plasma proteins. And so they start having hives and itching, and sometimes urticaria, and they have flushing, but they really don't have any temperature elevation. And they can just give Benadryl and everything resolves itself. There's the extreme of the allergic where people's mouths start swelling up and they can't breathe, and it's actually classified as more anaphylactic than allergic, but that's the extreme. Mild or pretty bad. Delayed non-hemolytic are things like malaria, which is very, very, very rare. There's been maybe a couple of cases, situations where the donor had malaria and went in and donated. I don't know that it's ever happened here. Same with babesiosis, maybe a handful of cases ever. They don't like to classify things like hepatitis, AIDS, in the delayed non-hemolytic, but really and truly that's where they probably belong. You get your unit of blood, and then further down the road, you've got a situation where you've got this disease that you don't have any respect for. Graft versus host disease can also fall into that, to the delayed hemolytic, delayed non-hemolytic, I'm sorry. So graft versus host disease being the recipient is very immunosuppressed. So they're a bone marrow transplantation for a young child or someone who's on heavy doses of chemotherapy, and they get units of blood, and for some reason the white cells, the HLAs, are enough of a match that the white cells start to propagate and attack the donor. Usually it happens if you have a donor who is a primary relative. So you have a patient whose father or son or brother, sister, mother went in and donated, so there's at least a partial HLA match there. Occasionally, if they're extremely immunosuppressed, it doesn't really matter. But we do irradiate units of blood to prevent graft versus host disease. It doesn't make the white cells go away, but it does keep them from reproducing. Nice drill over transfusion pictures. Okay, so what do we do about all this fun stuff? Don't do that. Okay, so anytime you have a situation where a patient dies or has suffered serious ramifications due to a transfusion. You remember I told you how computer systems and the blood bank are different because they're considered medical devices. Computer system can cause serious death and serious injury. So anytime that patient that we did everything right and they went up and hung it on bed B instead of bed A, has to be reported to the FDA. There's a Center for Biologic Evaluation and Assessment, I think is the sub area for it. Has to be reported within 7 days. And at that point in time, somebody from the FDA will come down and we'll do a root cause analysis with whoever's involved and the management. You guys know about root cause analysis? Yes, no? Well, generally what you sit around the table and you brainstorm about the processes that are involved that led to this led to whatever happened being allowed to happen. It's kind of a sketchy way to say it, but in other words, where are the holes in your process? So, okay, what do? You go up and you draw the unit at the bedside and you ask the patient, and the whole, from collection to transfusion, what are the steps involved and what do you do? And what can we do to make it better? And what part of this process actually is responsible of the person, the process, because they always stress that. The part of this process actually is the underlying cause of this particular problem that's happened, this death, this serious injury. At which point in time, then you come up with some sort of corrective action, some sort of process improvement that can eliminate that hole from happening. And then after you identify it, then you implement it. And once you implement it, then you let it go for about 6 months and then you assess it to see how effective that particular approach was. Do we need to tweak it anymore? Do we need to add more? But it's usually multidisciplinary approach to a problem because it's never one area that is solely to blame. It's usually more than one area that's solely to blame. Multiples. So, and if you think you have an infectious disease or something that is because the blood was in some way impaired, then you contact the blood center and you start an investigation that includes the blood center. If the blood's fine, everything's tested, the blood's great, and it comes over and you mess it up what you get, there's no real point in adding the blood center in there because what are they going to do differently? They didn't do anything. It was the process that was in the transfusion arena, not the collection and distribution arena. But if there's something that the blood center needs to be involved in, you can always bring them in to it as well. Okay, so when you investigate a transfusion reaction, nurse calls you and says, I think I have a transfusion reaction. Don't say, oh, that's nothing. Just keep going. That's not your responsibility. That's the clinician's responsibility. So the first thing they're supposed to do is stop the transfusion, leave the saline running. Do not close off that IV site. You may need that IV site further on down the line. Look at your unit. It is a requirement that when a unit of blood leaves the blood bank, the patient's information must stay on that unit until the transfusion has been completed. Now, the first thing they usually do is tear the tag off because they want to write on it. So you've got to find some way to keep that patient's name, medical record number, date of birth, whatever information you want to make sure is on there. Usually name and medical record number for sure. Anything additional will be fine. So what they need to do is go and look at that tag and make sure that that tag, that name that's right there, is that person that's laying in bed with the needle in their arm. Because if it's not, calling the blood bank really isn't going to help us a lot. They need to call the physician of that patient who's laying in the bed and say, I think I gave you the wrong blood, so they can get some sort of clinical action started for that patient's recovery. So you're going to check, make sure that the unit and the patient is the same. Then they're going to notify the blood bank. Okay, I've got a transfusion reaction. Okay. So then they're going to call the clinician. The clinician's going to say, oh, I don't think that's a transfusion reaction because that man's been spiking a temperature every 2 hours for the last 3 days. And he'll tell them to start, and then he'll come down for us. Or he'll say, okay, well, let's just stop the transfusion and proceed at that point in time. So they will send us the donor unit and a specimen. Post-transfusion specimen. And hopefully a urine. That's what they're supposed to send. They're supposed to send us all the IV tubing and the bag of saline, everything that's attached. They're supposed to send us the whole thing so we can look at it. So what we're going to do is we're going to go and we're going to look at that unit and we're going to see, is there a problem with this unit? Did they do something that could be a mechanical problem? I had one not that long ago, it was probably about a month ago, that they call a transfusion reaction, and they sent blood back, and the unit looked perfectly fine, and it was into the tubing, and where it hit the infusion set, all of a sudden it was just as hemolyzed as it could possibly be. So that was a mechanical. They were pumping hemolysis into the patients. Of course, they had a transfusion reaction because there was something mechanical with that infusion set. What it was they were infusing with the wrong IV solution. Non-normal saline is usually the only thing that you want to infuse blood with, although there's a couple of other solutions that they claim are okay. But that really wasn't that was a transfusion reaction, but that wasn't a blood bank transfusion reaction. That was a protocol transfusion reaction. But you could see it as clear as day because blood bag, blood goes down tubing, blood hits the little Y that connects with the infusion set, and all of a sudden there's all this hemolysis in the rest of the tubing. So we have to look at it and make sure it looks okay. How much did they send us back? They don't really, there's a range for how much volume is in a unit of blood. So to say how much was given is really hard, but how much came back is actually measurable. So how much came back? Did most of the unit come back? Did none of the unit come back? Did half of the unit come back? Sometimes you'll weigh it because 1.00 grams equals 1 ml, so you can do a 1-to-1 ratio to have some sort of idea. You tear out the weight of the bag, so you have some kind of an idea about how much was actually returned. So look at your bag. Make sure the tag belongs to the unit. There's nothing funky floating through the unit itself. A few years ago, they had a situation where they had white particulate matter that was in all these. You guys remember that? If you're not in healthcare at that particular point in time, you may not have remembered it, but they had units that came from the Red Cross that had white particulate matter in there. So it was like little, I don't know, chunks of powdered sugar that was in some of the units of blood, and they didn't really know why. I mean, obviously it must have been something that was due to the products themselves, not the blood, but everybody was kind of freaking out about the fact that you had all this stuff floating through there. So it turned out it was some of the anticoagulant that was precipitating out. So it really wasn't anything wrong with the blood, and it would have filtered out through the IV set, but all those units were recalled. So you want to look and see if there's something funky going on with your unit to make sure that there's not something you want to investigate as far as that's concerned. The first thing you're going to do is you're going to spin down your specimens, and you're going to look for hemolysis. Hemolysis is your big key to whether or not a transfusion reaction has occurred. So you're going to look at you're going to pull out your pre-transfusion sample, the sample that you did all your testing on initially, and this new sample, and you're going to compare the plasma. Is the plasma more hemolyzed on the post than it was in the pre? Then that's indicative of a possible transfusion reaction. It also could be indicative of a traumatic stick, but it could be a transfusion reaction. If they're about the same, there's more hemolysis in the pre, no big deal, but you're looking for hemolysis in the post that wasn't there in the pre. Then you're gonna do your urines, and you're gonna look for hemoglobin. So you have your little dipstick. It tells you whether there's red cells. Well, if it's red cells, I don't care about red cells. I don't care about hemoglobin. So I'm gonna spin it down and see if there's a cell button. If there's a cell button, then it's red cells. So I'm not gonna worry about that. Spin it down and there's no red cells. Possibility that there's a transfusion reaction. Was there hemolysis in the patient's urine for the transfusion? If there was, this hemolysis in post-transfusion means nothing. If there wasn't, then this could potentially be a transfusion reaction. So then you're going to take your pre-transfusion and your post-transfusion and your donor, and you're going to repeat the ABO and RH. Then on your pre-transfusion, your post-transfusion, and your donor, you're going to do a direct Coombs test. If the direct Coombs test was negative before the patient was transfused and now it's positive, that's indicative of a transfusion reaction. If it was positive before and after, could have a transfusion reaction. and something else going on? Hard to tell at that point in time. If it was positive before and now it's not, then you don't really worry about it too much. I can't see that would happen unless there's a big, giant delay. You're going to repeat the antibody screen. You're going to do an antibody screen on the pre and post in the donor. If the antibody screen was positive in the pre, then and it's positive in the post, that's kind of what you expect. If it was negative in the pre and positive in the post, that's strange. What's your time frame? Then you're going to recross-match that donor unit. Even if you did an immediate spin or electronic before, you're going to do Coombs phase this time. Possibility that you have a low frequency antigen that's causing an antibody reaction. So we're going to do the Coombs phase cross-match. Already jumped ahead with the urine check for hemoglobin. You're going to send part of the donor unit to microbiology for culture. Find out if there's any bacteria growing. And then, once you're finished with everything else, you're going to look at it and you're going to say, I wonder what caused this problem. Was it even transfusion related at all? Was it due to a sepsis? Was it due to circulatory overload? Was it febrile? Which one do I think is most likely the cause? If you had somebody, I had one the other day where the patient had a warm autoantibody, so it was really, really hard to know whether or not they had a transfusion reaction or not because there was so much work involved in the pre-transfusion workup that you had to reproduce in the post-transfusion workup. It was very, very sketchy as far as whether or not there was a transfusion reaction or whether they just had a warm autoantibody that was just lysing everything. It was that hyperhemolysis kind of thing. So sometimes it's not really clear cut, and that's why we have pathologists. Because then we can give all of our stuff to the pathologist, and the pathologist can go and look at the patient's clinical condition and know whether this is a mild allergic reaction or anaphylaxis, or know whether this is trolley and they need to do chest x-rays to find out if there's blood infiltrates, or know whether or not we need to reduce the time involved in a transfusion because the patient's going into circulatory overload because they weigh 75 pounds and we're trying to put 400 mLs of blood in them, and they just can't tolerate that volume. So they'll go and look and see what the correlation is between what we found and the patient's clinical condition, and then they will order additional tests. It can do direct Coombs. Basically, I do direct Coombs every few days until the direct Coombs is negative. If they have really have an antibody that reacted. Sometimes you might have O platelets that you gave to an A patient. You cause them to have a positive direct Coombs. You might want to wait till the direct Coombs is actually dissipated. You might give the patient Lasix, cause them to pee out a lot of the antigen antibody, or antibody more than anything in their system. And you might do, in extreme cases, you might do a plasma exchange where they actually draw off the patient's blood, spin it down, reinfuse the red cells, and give them either fresh frozen plasma that doesn't belong to them, or bilirubin, albumin, and saline. So basically, they take away the antibody and give them some nice, clean, super name for their cells to swim around in. But the physician, medical director, will give the physician his recommendations. They can do dialysis, bilirubins, haptoglobins. There's different testings that they can add on. Those are as needed.